I'm Dr. Tamru. Today we are going to have a seminar presentation on fluid in the electrolyte imbalance, which are a very common medical disorders and which are occurring in almost in every across department, every department. So we will discuss on this topic, and these are the outlines of the presentations. Admitted patient might develop hyponatremia. Yeah, ማለት almost 1/4 of every patient you admit will or might have electrolyte disorder, especially hyponatremia. So they are this very common, easy to diagnosis and easy to management. But if they are missed, they have fatal consequences up to days, like 60% mortality rate. Some of them have even permanent neurologic deficit, might develop even lately detect adregan, manage adreganacho, especially hyponatremia, they might develop permanent brain injury. So that's very important thing. So all of us should know at least for whom to detect electrolyte disorder, ለማን electrolyte መላክ እንዳለበት, and management of common electrolyte disorder. So that is the most important thing, or why we select this presentation, and it's all across all departments. Electrolyte disorder is not a problem of only patients admitted to the internal medicine. It is also common to occur in patients admitted to the pediatrics. It's also common in gynae and surgical patients. Especially hyponatremia is commonly to occur post-surgical patients. So it can occur all departments, across all departments. It's very common across all departments. So it is very important topic. All of you should understand and know, and I want you to actively participate on this presentation. So these are the outlines of my presentation. So I will go through brief physiologic components of body fluid. Then I will slightly say something about hypovolemia or volume imbalance, and I will discuss on sodium disorder and the potassium disorder. These are the commonest electrolyte disorder. Actually, these are not the only electrolyte disorder, but they are the commonest electrolyte disorder. So the remaining will be a reading assignment for the group. So in general, just to highlight, as you all know, almost our body total percent of our body weight is water. It is estimated to be around 60% of our total body weight is water. That means around 42 liters. So this percentage might vary with sex. In female, the percentage will be lower. It will be around 50 to 55% of the total body weight. So female will be water, and for male, total percent of 60% of their total body weight is water. So this water is distributed into two major compartments. These are intracellular and extracellular fluid. So the intracellular fluid are the predominant one. It accounts around 28 liters. Out of this 42 liters, or 2/3 of our body water is in the intracellular compartment. Then the remaining 1/3 will be in the extracellular compartment. The extracellular compartment has also further division to the interstitial fluid and intravascular fluid. So that's a very important thing. The interstitial fluid are the fluid that is between the cells, not inside the cells, but it is the fluid between the cells, or the interstitial space is called interstitial fluid. So it's around 10 liters, or 3/4 of the extracellular fluid will be in the interstitial space, and the remaining 1/4 will be in the intravascular fluid, or the volume that the blood that is circulating, the blood plus the plasma that is circulating inside our vessels are only around, estimated to be around 3.5 liters. So this is the total body components of our body fluids. So this is to show based on our age. You know, during the early on, almost we are water. In the early period, during the neonatal period, mostly our body will be water, but progressively, as our age progresses to especially around 12 to 15 years, we will reach to up to 60% of body fluids. As I said earlier, still male, the percentage of body component of male is predominant to the female in all compartments. Total body fluid, extracellular, intracellular distribution will be maintained. So around here in pediatrics, mostly the body fluid will be very high, but progressively as we grow, we will attain up to 60% of our body fluid components. So this is to show electrolyte distribution. So we have seen that the fluids and the body distribution, we do, as you know, we do have two kind of electrolytes, the cation and the anion, or the positively charged and the negatively charged. So imagine this is an extracellular, as you can see, this is an extracellular, this is intracellular, or so major extracellular cation is sodium. So sodium is major determinant of extracellular electrolytes, cation. So anion is major extracellular anion is chlorine. So these are major components of our extracellular. Then the intracellular components are, majorly intracellular component is cation is potassium, and intracellular components, the organics, the proteins, and the bicarbonates are major components of intracellular fluid components. So today we will discuss the major component, extracellular fluid components, the sodium, and from the intracellular components, the potassium. They are the determinant cation, both extracellular and intracellular. So there is always a balance between extracellular component and intracellular components of the anions. The integrity or the balance between the anions and the cations keep the hydration or the cellular fluid. So the determinant for the fluid levels are the balance between the electrolytes level. So that's very important. So electrolytes always we need to talk about fluid, because fluid ብቻውን move አያደርግም, or electrolyte ብቻውን determine አያደርግም. When there is electrolyte imbalance, there is concomitant fluid imbalance. When there is fluid imbalance, there is concomitant electrolyte imbalance, because the determinant for shift of the fluid is what? The level of the electrolyte. So the level of the electrolyte always determines the fluid levels of our body fluid components. So when there is much amount of extracellular cation, fluid shifts towards the predominant site. When there is predominant intracellular electrolytes increment, fluid shifts towards the intracellular. So like think of like this. Fluid always follows the electrolytes. So electrolytes dominate ወዳረገበት side, fluid shift ያደርጋል. Otherwise, the balance of our cellular component will not be maintained. So these are important terminologies: osmolality, tonicity, and effective osmoles. Osmolality ማለት just concentration of solutes that are solved in our body fluid components. Majorly, the sodium, the glucose, and the urea are major osmolalities or determinant of osmolalities of our body fluid. But from this effective osmolality, effective osmolality means the one that determines the direction of the fluid. So out of the three components, urea do not have effect on the fluid shifts. So the determinant for the direction of the shift of fluid are sodium and the glucose. So the effective osmolality ምንላቸው እነሱ ናቸው. So our body fluid balance, this is how we get fluids and how we excrete fluids. So mostly water we'll get from water, our body metabolism. Most water components are from what we ingest. Almost around 60% of water sources from what we drink or components of what we drink. Still foods, especially moist fluid, contribute around 30% of our water intake. And the remaining are from body metabolism. Excretion is also the same way. We lose fluid daily with the sweat, in the feces and through the urine. So major determinant is intake, 60%, and major determinant of fluid loss is the urine or the kidney is very important. So the urine, 60% of our body fluid is lost through the kidney or through the urine. So the healthiness of the kidney is very important for regulations of our body fluid. So sodium, as we said, our body osmolality will be maintained between this. So determinants for maintaining between these are water ingestion. So we do have thrust activation with the increasement of the osmolality. So we need water ingestion. The other, renal, very important. So renal healthiness is important for balancing our body osmolality. And the third and the very important is the hormone. The ADH or the vasopressin hormone is always important for balancing fluid and the electrolyte. So these three things integrate or work integrately to determine our body fluid component and electrolyte balance. So any derangement in the water ingestion or any derangement in the renal or anything affecting the vasopressin secretion, like as you know, diabetic insipidus, so will cause fluid and electrolyte imbalance. So AVP, just to highlight about AVP, ADH, these are the same things, antidiuretic hormone. So it is usually synthesized in the hypothalamus, and it is stored in the posterior pituitary. It is a hormone, and stimulating factor ምንድን ናቸው for AVP release? Blood pressure drop, blood volume loss, and plasma osmolality. Major role ምንድን ነው is keeping the hydration. So anything that cause hypovolemia will stimulate the AVP hormone. Then AVP hormone ምንድን ነው? Where did it act? It act in the kidney. In the kidney, it will ቅድም ስናወራ we have said here, this is a very important determining factor ብለናል። So when there is hypovolemia, the AVP hormone will affect this thing. 60% loss will AVP ምንድነው? Fluid retention ያመጣል ማለት. So the hypovolemia will be corrected. So that is where it acts. So the AVP hormone acts in the collecting ducts of the kidney and it causes fluid reabsorption. So the stimulant ምንድነው? The cause is hypovolemia. So the act is retention of fluid. So AVP acts there, and also it has effect on the vascular component. So vasoconstriction. So when there is vasoconstriction, there will be a rise in the BP manner. So that is the very important components of AVP secretion. So hypovolemia, yeah, as you know, hypovolemia is generally means combined salt and the water loss. Now, it is very rare. ስለ ኤሌክትሮላይት or water ስናወራ ሁሌ ሜጀርሊ ሎስ የተደረገው የቱ ነው እንጂ ነው የምናወራው እንጂ ወተር ብቻውን ሎስ አናረግም። ዩሪን ኤሌክትሮላይት አለው። ሜጀር ምንድነው በዩሪን ሎስ ያደረግነው? ኤሌክትሮላይት ፕሪዶሚናንት ነው ወተር ፕሪዶሚናንት ነው የሚለው ነው እንጂ always there is loss in both component, electrolyte and the water component. But when we say hypovolemia, predominant volume loss no, but there is concomitant electrolyte loss. So causes of hypovolemia, as you know, anything that can cause body fluid loss, like hemorrhage from trauma, any other thing like upper GI bleeding, or GI loss like diarrhea, vomiting, or anything that will increase the skin loss. ቅድም ስናወራ we have said small component of fluid will be lost through the skin or insensible loss. So anything that increase the skin or respiratory loss like burn will increase. These things will causes hypovolemia. And third space loss ማለት fluid accumulating into the third space. It could be ascites or it could be pleural effusion. Anything that cause shift of the fluid from the body component to the third space will causes hypovolemia. And the other thing, renal loss. So it could be extra renal loss, or hypovolemia can be extra renal loss or renal loss. Renal loss could be anything. Drugs could cause like diuretics, the usual Lasix and other thing that we cause. If there is imbalance or not corrected early, they can cause fluid imbalance. So that is a very important thing. Hypovolemia causes is very important thing. The next thing is knowing about the symptoms. So symptoms of hypovolemia, patient usually will be fatigue, weakness. They usually complain thrust, excessive thrust, because with the volume loss, thrust center is one of the regulating mechanisms. So for individuals with a healthy thrust center, they will complain excessive thrustiness, and the other is postural dizziness. And when symptoms usually, if these are early symptoms, but if they are not intervened, the symptom might be progressively severe. So patient will be oligouric or decrease in the urine. They can be contain abdominal, chest pain, and finally confusion, obtundation. So these are the usual causes of fluid disorder or hypovolemia. So physical examination of a patient with hypovolemia, they usually have decreased in the JVP, or and they will be orthostatic tachycardic or orthostatic hypotensive, or frankly hypotensive ሊሆኑ ይችላል, supine hypotension. So patient might, if not intervene, they can progress to hypovolemic shock, and they usually have peripheral hypoperfusion like peripheral cyanosis, cold extremity, and in pediatrics loss of skin turgor will be or delayed skin turgor will be the manifestation. So, and the other altered mental state. Laboratory usually with the hypovolemia, patient will have major determinant or regulator of fluid is kidneys. So with alteration of fluid, patient will have renal function derangement. They have increased BUN, creatinine, electrolyte derangement, and also urine. Electrolyte and osmolality is important for diagnosing possible cause, whether this is non-renal or renal cause of hypovolemia milone. Usually we can easily identify by doing urine sodium level. So if the urine sodium level is high, that means greater than 20, usually this is renal cause of hypovolemia, because renal, whenever there is fluid imbalance, the first thing renal do is conserving the electrolyte and the fluid reabsorption ነው የሚሆነው. So renal imbalance ካለ ግን usually renal derangement ካለ the electrolyte and fluid regulation mechanism will be altered, in the so patient will have increased in the sodium level. ግን extra renal ሲሆን fluid renal function intact ከሆነ usually the sodium will not be excreted, so sodium will be reabsorbed concomitantly fluid reabsorption አለ ማለት. So renal is compensating for the extra renal loss ማለት ነው. So whenever there is urine sodium less than 20 with hypovolemia, this is extra renal cause, and if it is renal, usually the urine sodium will be high. Theoretically, at least, we cannot do urine sodium here. Let alone urine serum sodium እየሰራን አይደለም. So management of hypovolemia, this is fluid loss. Usually it is resuscitation or hydration of the lost fluid component or the lost fluid, the management definitely. So the choice of fluid depends on the degree or the severity of the fluid loss. So if it's a kind of mild hypovolemia or mild dehydration, oral rehydration will be enough, no need of IV fluid or IV resuscitation. But anything extending beyond mild hypovolemia requires IV resuscitation or IV rehydration. The choice of fluid usually depends on the severity and the causes of the hypovolemia. So normal saline is usually preferred for a patient with normal sodium or hyponatremic patient with low sodium. Patient with low sodium or normal sodium with hypovolemia corner is sodium normal saline is preferred. For a patient with hypovolemia with hypernatremia corner, D5W is the preferred fluid. And if the cause of the hypovolemia is hemorrhage or bleeding or anemia, so blood transfusion will be the management or the resuscitation for normalization of the hypovolemia. So that is in general the management of hypovolemia. So this is just to brief or to give an highlight on the volume management. So the next one is sodium disorder. So sodium, as you have said earlier, it is a major extracellular cation. The normal sodium level usually ranges from 135 to 145. So anything below 135 will be hyponatremia, and anything above this will be hypernatremia. So usually disorders of sodium caused by either abnormality in water hemostasis. ቅድም ብለናል water alone or derangement አያመጣም, or electrolyte alone water derangement አያመጣም. Usually when there is derangement in one component, the derangement is both water and the electrolyte ነው። ግን which one is predominant የሚለው ነው determine የሚያደርገው the manifestation, the diagnosis የሚቀይረው which one is predominantly affected, is that the fluid component or the electrolyte component. So usually the sodium disorder is as a result of derangement in the fluid components, usually the cause ማለት. So to start with sodium disorder, the first one will be hyponatremia. So hyponatremia, as we have said earlier, anything below 135 for sodium will be considered as hyponatremia, and it is the most common, it is the most common electrolyte disorder for hospitalized or admitted patient. As you can see, the number, it ranges from 20 to 25%, or it will be estimated around 22% of patients, especially admitted patients, will develop hyponatremia. So if we admit 4 or 5 patients, one of it will develop hyponatremia by default. So this is the most common. So hyponatremia so can be classified based on for diagnostic important. Also, this classification also is also very important for management purpose. So we can classify hyponatremia into hypovolemic hyponatremia, euvolemic hyponatremia, and hypervolemic hyponatremia. So let's say simply understand in these three components. Let's say this is our body. So this is our body. Let's say this is 1 liter now our body contain የሚያደርገው and 1 teaspoon of salt ነው ያለን ወይም ሶዲየም ነው ያለን ማለት እንችላለን. This is the normal components of our body. So then when there is hyponatremia, we can classify these into three things. So ቀደም እንዳልነው it's not only sodium disorder አይደለም hyponatremia, is majorly the components of the water component ነው hyponatremia የሚያመጣው. So the first one will be hypovolemic hyponatremia ነው. So ይሄ 1 ሊትር የነበረው like 0.7 ሊትር ሆነ 1 ቲስፑን የነበረው half teaspoon ሆነ. So this is the definitions of hypovolemic hyponatremia. There is hypovolemic hyponatremia ማለት there is both decrease in the volume and the salt component ማለት ነው. But predominantly affected የሆነው ማን ነው? The sodium level ነው. There is a volume loss, but the predominantly affected one will be there is predominant decrement in the sodium level. So ቀደም እንዳልነው this አሁን ይሄ ከ1 ሊትር 0.3 ነው የቀነሰው. That's minor change, but the salt has changed from 1 teaspoon to half teaspoon. So that is what means hypovolemic hyponatremia. There is decrease both in the sodium and water component, but the predominantly decreased one or affected one is the sodium component. Then the next one is euvolemic hyponatremia. So this is normal 1 liter now, but the salt has decreased to let's say 0.7. In case of euvolemic hyponatremia, there is actually it's a kind of controversy, but let's say euvolemically slightly affected ነው እንደ hypovolemic አይደለም ግን at least normal ነው ያ volume 1 liter የነበረው የቦዲ fluid normal ነው ግን majorly affected የሆነው only the sodium component ነው. In case of euvolemic hyponatremia, the one affected is only the sodium. Hypervolemic hyponatremia ሲሆን the body fluid has increased to 3 liter, the salt has also increased to 3 teaspoon. ግን ምንድነው ባላንስ አያደርግም. hypervolemic hyponatremia ላይ hypervolemic hyponatremia ነው. hypervolemic ማለት the volume has increased ማለት ነው. hypervolemic means the volume has increased, but the sodium balance ለማድረግ try ለማድረግ some component will increase, but majorly volume ስለጨመረ the sodium will be affected ማለት ነው. So did you got me the difference between the three? So that's very important. በቃ sodium ስለ sodium ስናወራ always with the balance of the water ነው. ምክንያቱም ቀደም እንዳልነው ሶዲየምን የሚከተለው ማን ነው? ሁሌም ሶዲየም shift ባረገ ቁጥር water ነው የሚያደርገው ማለት ነው. ሃይፖቮሊሚክ ስንል ሁለቱም ቀንሰዋሉ ግን predominantly የቀነሰው ሶዲየሙ ስለሆነ ሃይፖናትሪሚክ ይሆናሉ ፔሸንቶቹ ግን በቮሊዩም ደረጃ ሁለቱም ቀንሰዋሉ. ኢዩቮሊሚክ ሲሆን ሶዲየሙ ብቻ ነው የቀነሰው, the fluid balance is normally. ሃይፐርቮሊሚክ ሲሆን ሁለቱም ጨምረዋሉ by default ማለት ነው. ፍሉዱም ጨምሯል ሶዲየሙም ያንን ኮምፐንሴት ለማድረግ ጨምሯል ግን የጨመረበት ሚንስ ምንድነው በሚያስፈልገው ኤክስፔክትድ በምንለው ሌቭል ስላልሆነ patient will be hyponatremic በጣም ፍሉድ ስለሚበዛ ማለት ነው. So that is how we classify. ይሄን ማወቅ አንደኛ ፖሲብል ኮዙን ለማወቅ ይጠቅመናል for the hyponatremia. ሁለት ማኔጅመንቱም የተለያየ ነው. euvolemic hyponatremia ሲሆን hypovolemic hypervolemic ሲሆን the management will be different things ማለት ነው. So that we discussed soon. So this is አሁን ያወራነው ነገር. The classification will be hypovolemic, euvolemic and hypervolemic hyponatremia. So hypovolemic hyponatremia ማለት anything that can cause loss in the fluid with electrolytes. So but predominantly there will be loss in the fluid component ማለት. So it could be extrarenal cause or renal cause. Extrarenal cause anything like diarrhea, vomiting, burn, pancreatitis. Extrarenal there is fluid loss with the diarrhea, with the vomiting fluid ይወጣል. diarrhea ሲኖር ኤሌክትሮላይት አለው by the diarrhea ግን predominantly water ኤሌክትሮላይቱን ይዞ ነው ስለሚወጣ ነው. both water and the sodium has lost, but the predominant one is the sodium one ማለት ነው that's euvolemic hyponatremia usually the common one from euvolemic hyponatremia is the SIDH or syndrome of inappropriate ADH secretion others like endocrine disorders mostly hypothyroidism glucocorticoid deficiency are the commons of euvolemic hyponatremia and the hypervolemic hypervolemic ነው ማለት ፔሸንቱ ኤደማተስ ነው ማለት ነው ያ ማለት heart failure renal እና non renal cause ማለት ነው non renal cause የምንላቸው it could be heart failure CLD አይደል renal causes CKD nephrotic syndrome are cause of hypervolemic hyponatremia hypervolemic patient means the patient is edematous ማለት ነው በሌላ ቋንቋ there is much amount of retained fluid ማለት I think it's clear ማስቆም ትችላላችሁ in case it's not clear so just to say one of the cause of euvolemic hyponatremia ካልናቸው ውስጥ SIDH ነው it is very common disorder it is syndrome of inappropriate ADH secretion ቅድም ያለው if you remember ምን ነበር ያለው ADH hormone will be released from the hypothalamus and it is important for keeping or balancing the fluid levels and electrolytes levels so there is sometimes there will be syndrome of inappropriate ADH secretion so it's usually it causes euvolemic hyponatremia because it causes retentions of both fluid and electrolyte from the kidneys most common cause usually is any malignant disorder primarily usually secondary to some other disease ነው የሚመጣው especially patient having like brain insult like stroke patients and patients with other disorder like pulmonary disorder pneumonia can cause SIDH so pneumonia patient ላይ hyponatremia ብናገኝ mostly due to syndrome of inappropriate ADH secretion ነው others like drugs and some other hereditary disorder stress endurance exercise almost anything literally can cause syndrome of inappropriate ADH secretion almost ማለት especially acute illness ሆኖ mostly ግን malignancy disorder pulmonary disorder and insult to the brain like stroke meningitis these things can cause ማለት ነው meningitis patient can develop hyponatremia because of the SIDH disorder so this is the criteria I don't go through detailed clinical diagnostic criteria allo will not be that important if you know meningitis patient or pneumonia patient where hyponatremia ካለው any other cause ሌላ loss ምናምን ከሌለው that's likely from SIDH so clinical features of hyponatremia so symptoms usually clinical features of hyponatremia usually depends on the magnitude and the rapidity of the potassium sodium loss so early mostly keep this in mind mostly sodium disorder symptoms are from the CNS and potassium disorder ደግሞ from cardiac condition K no potassium K from cardiac no potassium usually the symptoms of potassium disorder K for cardiac and sodium anything sodium usually predominantly affect የሚያደርገው brain and the brain related no hyponatremia so that is so we can classify them usually early patient might have headache muscle twitching or lethargy but as the severity progress patient develops seizure coma and they will die of respiratory arrest if they are not intervened early and managed usually it can cause respiratory arrest and finally death so we can classify them acute ማለት if the symptom or hyponatremia is usually less than 48 hours ከሆነ we call it acute and knowing this acute no chronic is very important by the management usually depend whether this is acute or chronic hyponatremia acute hyponatremia is a medical emergency so usually we need to rapidly correct the sodium otherwise patient will progress into coma respiratory failure and death and the chronic one usually ምንድነው is usually after 48 hours no chronic ምንድነው body has compensate አድርጓል ማለት ነው after 48 hours ምንድነው whenever there is hyponatremia ቀደም ብለናል imagine this is a brain so this is the extracellular fluid component so sodium whenever there is fluid shift የሚያደርገው ወደ ዳይሬክሽኑ ነው hyponatremia ስንል ምንድነው extracellular ምን ሶዲየም ቀንሷል ነው ያ አይደል so ስለዚህ fluid ወዴት ነው የሚሄደው ወደ ውስጥ ነው this is በቃ dilute ስለሆነ at least ፍሉዱን በመቀነስ ሶዲየሙን ኮንሰንትሬት ማድረግ ነው የሚፈልገው ቦዲ። ስለዚህ ፍሉድ ዊል ቢ ተዋርድ ዘ ሴል ነው ሽፍት የሚያደርገው ማለት ነው። ያ ማለት ደግሞ ምንድነው ኢዚሊ ብሬን ኤደማ ዲቨሎፕ ያደርጋል። ከሌሎች ቦዲዎች ፕሪዶሚናንትሊ ብሬን ብቻ አፌክትድ የሚሆነው ዜር ኢዝ ሊሚትድ ስፔስ። ሌላ ቦታ ሴሉላር ስዌሊንግ ቢኖር ዘ ቦዲ ካን ኮምፐንሴት but in the brain there is limited space for the limited extracranial space limited ስለሆነ symptomatic የሚሆኑት ሶዲየም because of the brain edema ነው ማለት so early ሲሆን emergency የሚሆነው ለዛ ነው because patient do not compensate patient usually develop brain edema so patient usually progress after 48 hours ግን ምንድነው our body ምንድነው ይሄን balance shift ለማድረግ intracellular ያሉ ካታዮኖችን ወደ ውጭ ያወጣል ላይክ ሌሎች ኢንትራሴሉላር ያሉ ፖዚቲቭሊ ቻርጅድ የሆኑ እንትኖችን ወደ ውጪ ስለሚወጡ አትሊስት ሲቪር የሆነ ሲምፕተም አይኖረንም because the fluid has የሚችለውን ያክል ፍሉድ ወደ ውጪ ሽፍት አድርጓል ማለት ነው usually chronic hyponatremia ሲቪር የሆነ ሲምፕተም አይኖረንም patient will be symptomatic but severe አይሆንም emergency ማይሆነው ለዛ ነው I think it's clear so acute ኮዞቹ ቀደም አውርተናል almost post operative patients commonly እኛ ኤክስፒሪየንስ የምናደርገው ሜዲካል ሳይድ HCT patient usually I think we have seen emergency ነበር yeah patients like HCT ከተጀመረ በኋላ usually in the first week patient will come bizarre behavior failure to communicate ምናምን ዲቨሎፕ አድርገው ይመጣሉ that is due to the thiazide diuretics so one of the cause of acute hyponatremia ከምንላቸው ውስጥ thiazide ነው so always whenever you have electrolyte imbalance ያለው patient ከሆነ look for the drug what is he taking usually so that's very important otherwise mislead ያደርጋቸዋል like stroke ስትሉ you will lose time unnecessarily investigate ይደረጋሉ like electrolyte imbalance ያላቸው CT scan ይላካሉ ሁለት ነገር ነው ሎስ የሚያደርጉት ፔሸንቶች financially CT scan የማያስፈልገው 4000 ብር ይነሳል and በዛ መሃል ዌስት የሚደረገው time is also very important time sensitive ስለሆነ management so always keep in mind electrolyte disorder easy to diagnosis easy to manage but mortality እንዳወራ ነው so these are ይሄን ያልካወራን so the treatment we will come to the treatment of hyponatremia so treatment usually depends on presence and severity of symptom duration of hyponatremia ቀደም ያልነው acute or chronic መሆኑና usually monitoring ያስፈልጋል because there will be risk with rapid correction will lead to osmotic demyelinating syndrome so that's a very important thing so in general principle of management mild asymptomatic hyponatremia ከሆነ doesn't need treatment like 135 ብለናል like 132 130 incidentally or ስንሰራ ብናገኝ that's a mild symptom የለውም so it doesn't require treatment just treat the underlying cause or the disease and if otherwise other management principle correct the underlying cause if there is extracellular fluid loss correct the volume then the sodium will correct and if it is hypervolumic hyponatremia ቀደም ያልነው classification we can easily management እዚህ ጋር ያልቃል so hypovolemic hyponatremia ከሆነ usually hypovolemia ነው if you correct the volume the sodium will correct so resuscitation with normal saline will be enough to correct the hyponatremia and plus you can sometimes supplement sodium chloride or table salt can be supplied in case of hypovolemic hyponatremia and in case of euvolemic hyponatremia usually you don't require another intervention just treat the underlying cause the sodium will be corrected in case of hypervolemic hyponatremia the first important thing you can do is fluid restriction ያስፈልጋል because these patients are hypovolemic heart failure ናቸው nephrotic ናቸው electrolyte free የሆነ fluid በወሰዱ ቁጥር electrolyte balance worsen እያደረገ ነው የሚሄደው so restrict the fluid and treat the hypervolemia if you treat the hypervolemia the sodium will be corrected how you treat hypervolemia like in case of heart failure you will intensify the diuretics the more patients are usually diuresed the electrolyte imbalance will be corrected ማለት so is that clear fluid treat the underlying cause and this is fluid restriction and treatment of the hypervolemia that means diuretics and other if there is another means for management you can manage so that's how you manage hyponatremia in general this is just an highlight so ምንድነው always keep in mind rapid correction will have a risk. So usually we don't need to correct the hypovolemia, the hyponatremia more than this. Greater than, usually you have to correct less than 8 to 10 millimole in 24 hours. ከዚህ በላይ correct ካረግን there will be a risk. There will be damage to the neuron and patient will develop osmotic demyelination syndrome and 48 hours should be corrected less than 18. ስለዚህ ምንድነው we need to frequently determine and rapidly correct እያደረገ ከሆነ ማኔጅመንታችንን ስሎ ማድረግ አለብን። ለምሳሌ hypovolemic hyponatremia fluid እየሰጠ ነው። If it is correcting beyond this, you have to hold the fluid for a while. Otherwise, rapid correction will lead to osmotic demyelination, which is a very devastating neurologic disorder. Patient usually will be presented with locked-in syndrome ይባላል። quadriparatic ነው የሚሆኑት and it will be like devastating outcome. So keep in mind, rapid, you have to frequently determine the electrolyte level and the correction should not exceed beyond 8 to 10 millimole per 24 hours. So this is just read on about these clinical features. They usually paraplegic or quadriplegic dysarthria, diplopia. It's very devastating. I have seen one patient and it's a kind of very devastating, a young patient. So this is all about hyponatremia. So hypernatremia is less common but high mortality rate. The mortality rate reaches up to 60%. So who are at risk of hypernatremia? These patients. እኚህን ማወቅ ምንድነው is important to determine electrolyte. Patient, infant patients, elderly patients. Hypernatremia ስንል is a disease when አንደኛው usually elderly patients hypernatremia is ምንድነው neglect ስለሚደረጉ ነው። bedridden የሆኑ ፔሸንቶች elderly patients, like any patient with psychiatric disorder, ውሃ ጠይቀው ውሃ የማይወስዱ ሰዎች are at a risk of hypernatremia. I think I am running out of time. So causes of hypernatremia could be renal loss and non-renal causes like insensible loss, like burn, others like osmotic diarrhea. Diarrhea, both hyponatremia and hypernatremia risk now. Osmotic diarrhea usually will lead to hypernatremia because the predominant cause osmotic diarrhea ላይ ምንድነው? fluid ነው። secretory diarrhea ላይ የሚባለው ደግሞ there is a secretion, both electrolyte and fluid ስለሆነ secretory diarrhea usually will lead to hyponatremia, but osmotic diarrhea usually like viral gastroenteritis might cause hypernatremia. So the clinical feature, as we said, predominantly neurologic no manifestation ናቸው. Patient usually they will have altered mental status, lethargy, weakness, irritability, and can progress to seizure, to coma level progress ያደርጋል. And usually against ነው የሚሆነው ማለት fluid ወዴት ነው shift የሚያደርገው hypernatremia ሲኖር? It's okay to ቀደም ሃይፖናትሬሚያ ስንል ፍሉድ ሽፍቱን አይተናል። ሃይፐርናትሬሚያ ስንል ሃይፐርናትሬሚያ ስለ ኤክስትራሴሉላር ፍሉድ ነው የምናወራው። so there will be predominant extracellular sodium elevate አድርጓል ማለት ነው። the fluid shift will be extra shift will be this one. brain አሁን ምንድነው የሚሆነው? shrink ነው የሚሆነው። ቀደም ኤደማትስ ነው ሃይፖናትሬሚያ፣ here shrink ነው። during the shrinking bleeding can happen. Patient might develop subarachnoid hemorrhage, subdural hematoma even might occur. So these are the general manifestation. So one of the cause for hypernatremia is diabetic insipidus or alteration in the deficiency in ACH level. It could be central or nephrogenic diabetic. Central ከሆነ just diabetic insipidus ከሆነ central ከሆነ usually ምንድነው there is deficiency in the ACTH level ማለት ነው። nephrogenic ከሆነ ግን ACTH level normal ነው, but the kidney is insensitive or resistant to the ACTH level. Central እና nephrogenic diabetic insipidus, how to differentiate? You have to read causeቸው ይሄ ነው። usually central causes usually infections like meningitis, brain abscess might lead to central diabetic insipidus, and nephrogenic usually chronic renal failure or CKD can lead to nephrogenic diabetic insipidus. Lithium, other electrolyte disorder by the hypokalemia can cause diabetic insipidus. So hypokalemia may result in hypernatremia, or hypercalcemia might also lead to hyponatremia. So that's a very important thing whenever you treat hypernatremia. So treatment briefly highlight hypernatremia. So when we say hypernatremia, is fluid disorder now. Basically, hypernatremia is usually a disease resulting from fluid loss. No? There is predominant fluid loss hypernatremia. So whenever there is hypernatremia, the treatment is resuscitation. Resuscitation, again, it should be depend on the target fluid should be calculated. And the choice of fluid አሁን ምንድነው ይቀየራል ማለት ነው። ቅድም ሶዲየም ዲስኦርደር ሲኖር ምን ነበር ስንሰጥ የነበረው ኖርማል ሳላይን ነው። ሶ ሶዲየም ፍሪ የሆነ ፍሉድ ነው ሪሰስቴት የምናደርገው ማለት ነው። ሶ that is D5W is or D5W is or dextrose fluid is the choice of fluid. So there is a calculation or a formula to calculate the total body or water deficit calculate እናደርጋለን and the water deficit will be replaced ማለት ነው። So the water deficit will be replaced by hypernatremia by the D5W. So this is a formula that you all need now. So to calculate the free deficit or water deficit is the sodium minus 140. 140 ምንድነው ታርጌታችን ነው። ቅድም ያልነው ከ135 to 140 ነው ያልነው as a normal sodium። ስለዚህ hypernatremic ከሆነ our target is at least to make minimum 140 ነው። ሶ ሶዲየም ማለት ደግሞ the current electrolyte calculate ያደረግነው ማለት ነው። ያ ማለት ለምሳሌ ዛሬ አንድ ኢመርጀንሲ የገባ ፔሸንት ሶዲየሙ 160 ከሆነ that is the sodium ማለት ነው። ሶዲየም 160 minus 140 is our target where we want to make the sodium divide by 140 times total body water. How do we calculate the total body water? አውርተናል እኮ ከኔ ጋር ነበራችሁ total body water ይሄ ነው ፎርሙላው አለና so sodium minus 140 divide by 140 times the total body water. እንዴት ነው total body water calculate የሚደረገው? ኤክሰለንት ቦዲ ዌይቱን ኬጂውን ካልኩሌት ታደርጉና 60% ወንድ ከሆነ 60% ሴት ከሆነች 50% of her weight will be her total body weight ማለት ነው። For example, if someone is 70%, so you will take the 70% of this ማለት ነው. You will calculate the total body water by taking 60% for a male and 50% for a female. Then you will bring some amount of volume ማለት ነው. So that volume will be the body deficit. እዚህ ጋር አያበቃም። ይሄ ዲፊሲቱ ነው። ከዛ በኋላ ደግሞ እስካሁን ያለው ዲፊሲት ነው። ዲፊሲቱ ፕላስ ዛሬ ደግሞ ምን ያስፈልገዋል? ፍሉድ ያስፈልገዋልና so deficit plus maintenance ነው መሆን ያለበት. If you replace only the deficit, still ፔሸንቱን ከዲፊሲት አላወጣ ነው። ይሄ እስካሁን ያለው ዲፊሲት ነው። ለዛሬ ደግሞ የሚያስፈልገው አለ። So you have to add also the daily maintenance. The daily maintenance plus the deficit will be calculated on ይሄ መቼ ነው ሪፕሌስ የሚደረገው? the deficit minimum for 48 hour ነው ካልኩሌት የሚደረገው ማለት ነው። ስለዚህ ዲፊሲቱን ካልኩሌት አድርገን around 3 ሊትር or 4 ሊትር ከመጣ 4 ሊትር ቢመጣ the first 24 hour 2 ሊትሩን ይወስዳል። the next 24 hour it will take the remaining 2 liter ማለት ነው። This patient require 4 bag of D5W ማለት ነው። Then in between you will determine the serum electrolyte and you will correct the remaining thing ማለት ነው። So እነዚህ ማለት ይሄ insensible loss እነዚህን ካልኩሌት አድርገን daily maintenance እንጨምርበታለን ማለት ነው። So that is how you manage all in all hypernatremia. Read on about how to differentiate central versus especially the GPs, peripheral, central versus nephrologic diabetic insipidus, water deprivation test ምንድነው? How to differentiate between primary polydipsia versus diabetic insipidus. They are very important ማለት ነው። So that is sometimes እንትኑን if we can get free water በኤንጂ ቲዩብም ሪፕሌስ መደረግ ይችላል። keep in mind that free water with energy tube replacement water deficitun በኤንጂ ቲዩብም ሪፕሌስ ማድረግ ይቻላል። other thing usually like central እና እንትን there is a so called gestational diabetic insipidus especially occurring in the third trimester pregnancy. In those cases like diabetic insipidus no, so the deficiency is AVP hormone, so replace the AVP hormone. And the other thing, like in case of nephrogenic cause. If it is a drug cause, drug should be removed or drug should be discontinued. So potassium disorder. So I think either you will read potassium disorder is not that complicated as to that of sodium disorder. They are very easy to understand, and both hypokalemia and hyperkalemia ነው ከዚህ በኋላ ያለኝ ግን they are not that complicated and easy. I think this PowerPoint will suffice to read. So ምንድነው hypokalemia means serum potassium level less than 3.5 ነው. Is as common as sodium. ቅድም hyponatremia is common, we have said around 22%. Hyponatremia is still common up to 20%. And mortality, look at how much the mortality will increase. There is 10 times increased risk of mortality with hypokalemia. So don't underestimate electrolyte disorder. So causes እነዚህ ናቸው. Usually insulin የሚወስዱ patient አይደል? DKA ስናወራ DKA ማኔጅመንት ላይ ዲስከስ አድርገናል አይደል? DKA anything like acid based disorder and like non-renal cause like vomiting, diarrhea still can cause hypokalemia, and renal cause like diuretics. Diuretics ላይ usually furosemide አይደል? The loop diuretics usually causes hyponatremia. Spironolactone add የምናደርገው is to prevent this hypokalemia because spironolactone usually they causes potassium retention. So that is very important thing. So other things like anabolic state can cause this. Usually clinical featureዎቹ ምንድነው? K ምን ብለናል? for cardiac. ስለዚህ cardiac disorder ነው. usually ECG ነው ብዙ ጊዜ ሌላ እንደ ሶዲየም ኮማ ምናምን አይኖራቸውም። mostly ይሄኛው worse የሚያደርገው ለዛ ይመስለኛል because clearly anticipate አድርገን possible risk አለው ብለን determine ካላደረግን briefly የሚታይ like እንደ ኮማ lethargy ምናምን symptom sometimes mostly we don't expect. That's why mortality will be very high. Like ECG disorder will be, these are the typical ECG manifestations, and mostly cardiac ቀጥሎ skeletal muscle usually affected with will be affected with hypokalemia. They might have weakness even to the level of paralysis. There is a so-called hypokalemic periodic paralysis. Quadriplegic ነው የሚሆኑት patient. Then the good thing when the potassium is replaced, the quadriplegia will resolve. So treatment usually is replacing hypokalemia ከሆነ is replacing the potassium deficit. Calculate እናደርጋለን. KCL will be administered. KCL usually will be administered with drip አይደል? with fluid ነው መሰጠት ያለበት. So if you give IV push potassium ምን የሚሆን ይመስላል? IV push ቢሰጣቸው ፔሸንቶች the nurses, that is ቀጥታ days ነው. After 2 minutes you will find the patient at morgue ማለት ነው. So that's medical እንትን ምንድነው ይባ okay I forget the terminology. ሜዲካል ብቻ ያው ተርሚናል ፔሸንቶችን if they don't want to continue legal የሆነባቸው ሀገሮች ላይ it has medical terminology that euthanasia. So terminal patient, cancer patient legal የሆነባቸው ሀገሮች ላይ if they don't want to continue, if they want to die, you will give them KCL push and they will die. So that is always. And the other thing, don't forget KCL should not be given with dextrose or D5W መስጠት የለበትም. It should be given always with normal saline because the D5W is it has some osmolality. When you add the KCL also it will also increase that. So that's how you treat. So hyperkalemia is the same thing. Hyperkalemia is also cardiac, no? Usually progressive የሆነ symptom አለው is cardiac disorder ነው. So መጀመሪያ they will have like this tall peaked wave, P wave, then QRS widened ይሆናል. Finally they will develop arrhythmia, ventricular fibrillation, and patient will die ማለት. So these are the treatment. Usually treatment ምንድነው? hyperkalemia ከሆነ removing the potassium from the body ነው. How will we remove? By giving glucose with insulin. Insulin ምን ያመጣል? shift ያመጣል ማለት ነው. hyperkalemia there will be shift whenever you administered insulin, so it will shift from the extracellular component to the intracellular component. So insulin with glucose will help you to reduce, and cardiac protection ያስፈልጋል. even if calcium gluconate should be given. Calcium gluconate will be given not to treat the hyperkalemia, is for cardiac stabilization. So that is, you have to always keep in mind. In hyperkalemia patient, we will give calcium gluconate to stabilize the cardiac. The hyperkalemia will be treated with insulin and the glucose. And there are some, they are not that much important, but drugs that can be used. But finally, if it is refractory, the treatment will be dialysis. Dialysis will remove the potassium from the body. So that's a brief highlight. So thank you.